Good morning, and thanks for having me. So I would like to start off my talk with a case presentation. This is not moving. What's happening? This mouse? Okay. All right, thank you. All right, so I'm going to start off the case with the case presentation. This is a 65 years old female, progressive dyspnea on exertion and chest pain for past year and a half, class 3 symptoms, has had previous hospitalizations for heart failure. Comorbidities include hypertension, diabetes, and chronic kidney disease stage 3. Has a history of chronic atrial fibrillation and is on a rate control strategy as well as anticoagulation. Physical examination, jugular veins are mildly elevated. There's trace peripheral edema. In terms of lab work, NT-proBNP is mildly elevated at 627, creatinine's 1.7. She is not anemic. In terms of cardiac medication, she's on Lasix 40 milligrams daily, lisinopril 5 milligrams daily, beta blocker, statins, and glipizide for diabetes, as well as anticoagulation with Coumadin. EKG, I'll just go over what it shows. Shows atrial fibrillation with right bundle branch block as well as a left anterior fascicular block. This is Mayo format, so the LV's on the left side. Sorry. I hope there's some problems. So basically, LV showed normal LV size, EF of 55%. Left atrial volume index was elevated 72. So because of the patient's shortness of breath and chest pain with exertion, she underwent a cardiopulmonary exercise test that showed a peak VO2 of 10.8, which is significantly reduced. RER 1.23, suggesting it's an adequate test. VE VCO2 of 39, which is clearly abnormal. Anything above 34 is considered abnormal. Peak heart rate was 153, and patient did not have an adequate blood pressure response to exercise. Next slide, please. This is the patient's coronary angiogram briefly. Can you go back to it, please? Click next. Essentially, what it's showing is that there was no significant coronary artery disease. Patient went for a right heart catheterization. As you can see, the mean RA pressure was elevated at 15 millimeters of mercury. The wedge was elevated at 23 millimeters of mercury. Patient had severe pulmonary hypertension. And if you look at the transpulmonary gradient, it was 27, that giving you a PVR of 6.9, which is severely elevated in terms of pulmonary vascular resistance. Next slide. Because of these hemodynamic parameters, this patient underwent a drug challenge study. And in this, you can see that with nitric oxide challenge, the wedge actually increased. Mean PA pressure did not come down much. The cardiac output actually dropped. But as a result of the wedge going up, the PVR was reduced. So this is a phenomenon called reactive pulmonary hypertension that you would see with heart failure with preserved ejection fraction. Next slide, please. So this is the pulmonary capillary wedge form at baseline, and what you see post-nitric oxide is that you see a really prominent V wave. It's almost hitting 60 millimeters of mercury at end expiration, suggesting that this clearly, these hemodynamics are consistent with heart failure with preserved ejection fraction. You know what, I might be able to do it myself, so you could just, okay. So the diagnosis here is just going to be heart failure with preserved ejection fraction in the interest of time here. So the important thing is, what is the, how would you treat this condition? That's the important question here. How would you treat this patient who has heart failure preserved ejection fraction? Would you treat them with neurohormonal modulation, including a beta blocker, ACE inhibitor? Would you consider something as a new novel device called a CardioMEMS device, which is a PA pressure-guided heart failure pressure monitor, PDE5 inhibitor like sildenafil, or rhythm control? So one thing that, I'm sorry that there's time issue, so I want to go over the points here, the main points. One thing I want you to understand, that heart failure with preserved ejection fraction is characterized by two main issues. Number one, is elderly age. Number 2 is comorbidity profile. This is basically the cardiovascular health study in which they had 5,000 community-dwelling patients, in which you would see that the prevalence of heart failure above the age of 66 was about 10%, but 80% of these patients had an EF of greater than 45%. So the first point is HFpEF is a diagnosis of the elderly. Next slide, please. The other thing is that it is defined by a whole host of comorbidities. In terms of non-cardiac comorbidities, the important ones I'll highlight for you are renal dysfunction, very common. Chronic kidney disease stage 3 is a very common diagnosis to have in HFpEF. COPD, obstructive sleep apnea, and obesity. These are 4 very key non-cardiac comorbidities that accompany heart failure with preserved ejection fraction. Next slide. And on average, patients with HFpEF have at least 4 comorbid conditions, just to tell you what kind of comorbidity profile HFpEF patients are accompanied by. Next slide. So the thing I want to highlight here, in terms of cardiac comorbidities, the 3 most common comorbidities in HFpEF is coronary artery disease, prevalent in about 1/3 of patients, hypertension, and atrial fibrillation. So I want to set up the stage that HFpEF is characterized by elderly patients with several comorbidities. Next slide, please. And next, click. So the other thing is that atrial fibrillation is so common in heart failure preserved ejection fraction that 2/3 of HFpEF patients at some point will either have or develop atrial fibrillation. Next slide. So this sets up the stage for what is the pathophysiology of heart failure preserved ejection fraction. So if you see now all these comorbidities that I told you that HFpEF patients have, that results in a systemic inflammatory process with IL-6 and TNF-alpha predominantly being the inflammatory mediators. Downstream, that results in generation of reactive oxygen species, the net effect of which is decreasing the nitric oxide pathway. The nitric oxide pathway, in very simplistic terms, is your anti-fibrotic pathway. The other thing that the systemic inflammatory process triggers is the TGF-beta pathway, which is your pro-fibrotic pathway. So in other words, this systemic inflammatory process is generating a pro-fibrotic pathway that downstream results in heart failure with preserved ejection fraction. Next slide, please. So hence, it's not that difficult to understand the pathophysiology of heart failure. Because you have this systemic inflammatory process resulting in pro-fibrotic state, you have increased in ventricular stiffness. This could be at the extracellular matrix level with increased collagen, or at the cardiomyocyte level with abnormalities in titin and other things. But bottom line is that this pro-fibrotic pathway resulting in increased ventricular stiffness. This same phenomena goes on in the vasculature as well. You have increased vascular stiffness. This sets up the hallmark, one of the hallmark pathophysiological mechanisms of HFpEF, which is abnormal ventricular arterial coupling. Now, the other thing that I want to point out here is that HFpEF was a change in terminology. Previously, we thought of this as diastolic heart failure. So what's different? Well, the thing that's different is there are other issues that are going on that are not diastolic heart failure. Number 1, they have chronotropic incompetence. Number 2, they have poor systolic reserve. As a matter of fact, there have been a lot of echo data that shows that these patients, in fact, may have a normal EF, but they don't have a normal systolic function. And definitely with exercise, they're unable to augment their ejection fraction normally. So there's a mild systolic dysfunction or subclinical systolic dysfunction, at least as evidenced by ejection fraction. So there is more to HFpEF than just diastolic heart failure. So that's something to remember. Next slide, please. So what is the prevalence of HFpEF? Most people may not realize that half of all heart failure patients admitted to the hospital have heart failure with preserved ejection fraction. Next slide. And this incidence seems to be increasing over time. So as time has passed by, the incidence, the prevalence, of heart failure preserved ejection fraction has been increasing. And then some people think that that's more, you're diagnosing the condition more, but more importantly, what's happening is a changing demographic. It's basically an aging population with more comorbidities resulting in an increase in the prevalence of heart failure with preserved ejection fraction. Next slide, please. And so in observational data, just to highlight the point that the mortality with HFrEF and HFpEF is about the same. Having said that, in clinical trials, click once, please. In clinical trials, the outcomes have been shown to be better in HFpEF than HFrEF, but in true observational studies, actually the mortality is very similar. Next slide, please. So this is what I'm laying out to you is a very basic diagnostic algorithm. I think you will find it very helpful. If you have a patient who has heart failure symptoms and an ejection fraction of 50%, the next step would be do an echocardiogram. In echocardiogram, mostly we look at something called a tissue Doppler. And if you use a cutoff of 8 or less centimeters per second on a tissue Doppler, that's actually quite useful. Because if you have someone who has a normal tissue Doppler velocity of greater than 9 centimeters per second, then you're really probably not dealing with diastolic dysfunction or HF-PEF. You probably need to look at other conditions like constricted pericarditis, for example. So if you do have a reduced tissue Doppler velocity, then these are other things that will help you would help you in terms of establishing evidence of elevated LV filling pressures. What if your echo is indeterminate? That is when you want to proceed with a right heart catheterization. Next slide, please. So one thing I don't want you to miss is that just because you have heart failure preserved ejection fraction, there's several other conditions that are not HF-PEF that can cause what appears to be on that diagnostic algorithm that I shared with you, heart failure with preserved ejection fraction. For example, hypertrophic cardiomyopathy, infiltrative cardiomyopathy like cardiac amyloidosis. This is not HF-PEF. Yes, they have preserved ejection fraction, they have heart failure symptoms, they may have abnormal diastology, but that is not HF-PEF. So you need to look for other differential diagnosis. Make sure you rule that out before you give someone this diagnosis. One click, please. And in that ballpark, I want to give you one useful tip. If you look at your LV septal wall thickness on a transthoracic echocardiogram, and if it is greater than 15 millimeters of mercury, very rarely does hypertension cause LVH that exceeds 15 millimeters of mercury. Anything 16 and beyond, you have to look for other things like hypertrophic cardiomyopathy, infiltrative cardiomyopathies like cardiac amyloidosis. Next slide, please. So let's get into the management. In general, neurohormonal modulation that you have seen in HF-ref that has been so beneficial and is kind of the mainstay of treatment of stage C heart failure does not apply to HF-PEF. Next slide. So if you look at this is a meta-analysis of the RAS inhibition in HF-PEF, and in terms of the 3 major trials, CHARM preserved, PEP-CHF, and I-preserved, there was no overall improvement in heart failure hospitalization or mortality. Next slide, please. So the TOPCAT trial looks at the MRAs, or aldactone, in this case, spironolactone. This was a well-designed trial, but this again did not show any improvement in the primary composite endpoint of cardiovascular death, heart failure hospitalization, or resuscitated cardiac arrest. Next slide, please. However, in terms of heart failure hospitalization, spironolactone did show a mild benefit, and this was statistically significant in the TOPCAT trial. Next slide. And I'm going to skip this slide, so next slide. What about beta blockers? So the seniors trial was one of the trials of nebivolol in heart failure that I think to some degree studied HF-PEF. They used an EF of 35%, greater than 35% as the definition of HF-PEF, which we can debate that probably wasn't an appropriate classification. But nevertheless, again, this did not show any difference versus placebo in terms of all-cause mortality or cardiovascular hospitalization. Next slide, please. So then came the RELAX trial. Now, I explained to you that by enhancing the nitric oxide pathway, you could potentially create an anti-fibrotic milieu, which may translate into improved outcomes in heart failure with preserved ejection fraction. Well, that was the rationale for the RELAX trial. And PDE5 inhibition with sildenafil was tested in this trial. And next slide, please. And again, unfortunately, this trial did not show any improvement, and that their primary endpoint was looking for objective evidence of increase in exercise capacity using peak VO2 assessment. Compared to placebo, sildenafil had no benefit in terms of change in peak VO2 or improvement. Next slide, please. So what about nitric oxide precursors like isosorbide mononitrate or nitrates? This was studied recently in the NEAT HFpEF trial. And one of my mentor, Dr. Redfield, was on this, and it was a heart failure clinical research trial. Please, next slide, please. And unfortunately, this did again show no improvement in exercise capacity in terms of IMDUR versus placebo. the way they measured exercise capacity was a novel way using measuring something called accelerometer. I didn't have time. It would be interesting to go over that at some point later. Next slide. Now, when I was a fellow at Mayo, Dr. Borlaug did this study of inorganic nitrates, participated in almost all of these patients' trials. Essentially what they did was we took patients with HF-PEF, exercise right heart cath, and determined how their wedge pressure increased with exercise. Then we randomized them to either nothing versus inhaled sodium nitrite inhalation for 15 minutes. And then we did an exercise right heart cath again to determine their wedge pressures. And this was a small set of 30 patients, but it showed that if the patients who received sodium nitrite, their wedge pressure decreased by about 12 millimeters of mercury with exercise prior to without not having that at baseline. So there's intriguing, but this has not been translated into a clinical trial yet. Next slide, please. So IVABRADINE is a selective sinus node inhibitor. It was studied in HFrEF and now has a class 2A recommendation, but it was also studied in a small randomized control trial in HFPEF. 61 patients, they were randomized either to IVABRADINE 5 milligrams twice a day versus placebo. And the rationale for this is that, the diastolic filling time. So in HFpEF is all about diastolic filling time. So by controlling heart rate, you might improve outcomes. In this situation, it showed that IVABRADINE improved peak VO2 and METs. Can I take some time because of the, okay. All right, so improved peak, improved peak VO2 and improved metabolic equivalent. So this is intriguing, but this is a small study that would need further characterization in a larger trial. Next slide, please. What about statins? So statins, by the way, other than reducing lipids, obviously has pleomorphic and anti-inflammatory effects. So all that I told you about the pathophysiology, it is intriguing that statins might have some benefit. Unfortunately, there are no randomized control trials studying statins in HFpEF. Having said that, there have been several observational studies that in fact have shown a survival benefit with statins. Having said that, because there's no randomized control trials, next, click one time, please. It has not translated yet into the guidelines. So currently, statins is only used if you have an indication, like atherosclerotic heart disease. Next slide, please. So I want to jump to one thing real quick, is the CardioMEMS heart failure system. This is basically a PA pressure sensor that you implant in the descending branch of a pulmonary artery. It endothelializes in 1 month. And next slide, please. And hence does not require antiplatelet therapy. So this is the patient lays on a pillow every night or every morning and then transmit these pressures that transmit to a computer that is available to either whatever your heart failure disease management program has, either a registered nurse or a nurse practitioner who's monitoring these pressures on these patients on a daily basis. Next slide, please. And in HFpEF, in the CHAMPION trial, it showed a 50% relative risk reduction in terms of reducing heart failure hospitalizations at 6-month follow-up. So far, what I've told you, CardioMEMS device, implanting someone who is having recurrent admissions for heart failure, who have preserved ejection fraction, this is one measure they may actually reduce heart failure hospitalization. So that's one take-home point. Next slide, please. There is, just out of curiosity, there's a new there's a new device. It's called an intra-atrial shunt device. Patients who have elevated left atrial pressure on diuretics, medical management not improving. This is a reduced lap heart failure trial that is currently completing enrollment, is testing this intra-arterial device in HFpEF patients, which will be intriguing how that improves, how that translates into outcomes down the line. Next slide, please. So last comment about exercise and weight loss, definitely exercise and weight loss helps. It improves exercise capacity. This has been shown in multiple studies, but who cares, right? This is overrated. Actually, it's so overrated that Medicare has not approved this as a method of payment. So for HFrEF, you can, Medicare has approved cardiac rehab, but not for HFpEF. Next slide, please. Next slide, please. So next slide, please. So in conclusion, hopefully I can take control of this slide. Okay, no. All right, single clicks, all right? So HFpEF represents half the entire heart failure burden. Next point. HFpEF is characterized by age and comorbidities. what it lives with. HF-PEF may be a consequence of a chronic systemic inflammatory state driven by underlying comorbidities. Mortality is at par with HF-ref in observational studies. Neurohormonal modulation has not proved to be helpful, but one quick point, there's a category of patients that had HF-ref but then improved their ejection fraction and now will be classified as HF-PEF, but these are patients who are on neurohormonal modulation therapy and improved. They should continue on neurohormonal modulation therapy. I'm talking about de novo HF-PEF. Rhythm control, if sustainable, may help improve symptoms. AFib rhythm control is what I meant. CardioMEMS device is the only intervention that is shown to reduce heart failure hospitalizations. Maybe the TopCat and spironolactone could do that. And there are new therapies on the horizon, including IVABRADINE and this intratracheal shunt. And sorry, and thank you very much for going over time.